Very good. So we are recording. So what we're going to, a couple of things. I'm going to try to get through much of the rest of the immune system. Basically, our focus point is going to be antibodies today, and then we'll work from there. So I think that's really the first. I'll be using a little bit of just a different PowerPoint so you can visualize some things about antibodies, and we'll go into we'll start to look at some problems when the immune system doesn't work properly. I've run into the same problem with my micro class, and I told the other section for your class, because we still have a lot to cover. I don't know why this term maybe has gone slower than before. Trying to adjust what I'm covering and what I'm not covering. They did ask us to cover a little bit more this term than we did last term, so to speak. But because of that, I think we're going to probably have to have this third exam, and I haven't really focused on a date. I'm probably going to do it on Blackboard. Yeah. Final, I can't do that. I know we have some issues here with the final and being on the last day. You're right, the Friday group. I'll talk to him. I didn't get a chance to talk to him today. My boss about that, how we proceed with how I can arrange that to provide some alternative times. I'm not objectionable if I'm allowed to do it other times that I'm here giving finals if they work with your schedule. We'll just have to see. But long story short, so I just don't want to use up class time because I need to lecture to you. And I hear in the lab here, I think you're in the same kind of a conundrum too, as well, from what I'm hearing about what you're going to be covering in the lab. I know Dr. Robbins estimated missing a week and all that good stuff. So we got what to do. So that's more on that. I'll have more specifics, I hope, Wednesday, Friday latest about all that stuff. Okay. So because we have a little more time, what do we have? We have this whole week and next whole week, and then 2 days the following week, right before effectively the long weekend for Easter, right? Boy, not seeing a lot of enthusiasm here. Let's go. Moving on. Today we're talking antibodies. Antibodies are these funny looking things that look like a Y or a letter T. So you can see them there. And effectively, what our body does when we encounter an antigen, we effectively make an antibody to basically designed to lock onto it. So if this is the part of the antigen, if it's the tip of a pencil, the tip of a marker, or an eraser, we construct something that's going to latch onto it. And that becomes the so-called active end, okay, or specialized end, or variable end is the terminology that we use here. And effectively, you're going to see that this is the portion where it's constructed within the context of something called a plasma cell. And the plasma cell is a modified white blood cell in the B cell line. You can think of B for antibody if you want, just as easily. That turns into really a big factory, producing, when it's active, thousands of molecules every second of these antibodies. We produce vast amounts of antibodies in a very, very short period. Over a short period. It takes a while for that to ramp up. We'll get to that in a second. Once they're active, oh boy, they get busy. They have somewhat of a lifespan in that regard. So that's the first thing we're going to look at. And they're just giving you an idea diagrammatically how the exposure, they're active, they clone or proliferate, and they eventually begin to produce these. They become something called a plasma cell, which is a modified lymphocyte that produces these antibodies in droves. And again, it takes a fair amount of time, usually a minimum of about 5 or 6 days for them to become active the first time they're exposed to this fashion. And then a fair amount of them become this memory cells. Memory cells are part of our immunological memory. We're going to look at that later in this PowerPoint sequence about it. It's the whole idea behind immunization for vaccines. They're there. And this just gives you an idea. And basically, it's a summary. It doesn't have to be bacteria or a virus that's just floating around that triggers this. You can have a lot of different ways to ramp up antibody production. It can be a bacteria or virus that enters into the area, encounters a particular B cell, okay, and then either by the B cell by itself or with the aid of a helper T cell, that cell that helps all parts of the immune system. It causes that B cell to proliferate or clone, and that eventually, and the difference is that the memory cells last a very long time, perhaps even your lifetime. The plasma cells that make the antibodies become very busy after about 5 or 6 days. Usually, after about 14 days, they begin
Someone's
to
camera's on
become less active.
and
By 30
mic.
days, they're gone. That's the difference. This is a part of the immune system that doesn't require an off switch. Cells have a lifespan, and antibodies have a lifespan. They're going to deteriorate over time. That's interesting. Okay, that's one of the difference when we start to see problems with immunological diseases. There's different things that account for them. In this case, we don't have to have another cell saying to these antibodies, "Stop making antibodies. You got rid of the bacteria is gone. Good job." We don't have to worry about that. It's not. It's just one of many problems that we don't have to worry about in this particular system. Again, it could enter the tissues, and in this case, it could encounter an antigen-presenting cells. And an antigen-presenting cell works very, very similar to this. It just happens to, it works a little bit differently in the sense that typically it presents it to a helper T cell. The helper T cell then basically activates another B cell, and the B cell makes a plasma cell. So there's a lot of different roads, but the end product is the same, antibodies. And antibodies are not all the same. They're different structurally, and they're different, as you can see there, in the major types of them. But what they all are proteins. They're a big globule of protein. So in the category of globular proteins, those are ones that are by definition soluble in the bloodstream. And the ones that make the antibodies are called gamma globulins. You remember in the blood, we had the albumin was 60% and about 36% were globulins. Some of those were beta globulins. They were ones that carry the fats that circulate through our bloodstream. That when we look at people who have problems with tolerating fats or having what they call lipidemias, the agents that carry them from cell to cell so they can be utilized appropriately or at times with difficulty, those are beta globulins. That's not this fraction. This fraction is gamma globulins. And indeed, before we knew a lot about them, we used to isolate gamma globulins, extract them, and give them as a treatment. Before we really knew the specifics about how to treat certain things, in the old days, the early treatment, even back as to the Korean War, they would give people a big shot of gamma globulin, which somebody produced it. They were able to spin it down, isolate that fraction, extract it just the way with siphoning off and spinning it down with a centrifuge, and inject that into people if they were a compatible donor, just to bolster their immune system. That was the old treatment. Now we have an immunization for hepatitis A. So gamma globulin treatment was sort of a general booster when we felt that the immune system wasn't making a sufficient amount of antibodies. Just historically, I thought that might be interesting to you. So we call them another name, are immunoglobulins. You'll see the combination. They have 4 polypeptide chains, which are amino acid chains, 2 heavy and 2 light. Okay? And I'll flip over here real quick so you can see what I'm referring to. No, they have it over here, so I'll go in this direction. So effectively, the heavy chain is the darker chain here, and the darker blue or purple. This is the constant area. The constant area are the darker colors of both the light blue and the purple. The ones that are down here, these double S's are called disulfide bonds. We see those a lot in proteins that impart structural stability. This is the so-called constant region. This area where the stem is and the base of the Y, that determines what category it's in. There's 5 major categories that you will see very shortly. This is the variable end. That's the part that that plasma cell tailors uniquely to whatever the antigen is, whether it's one of a couple hundred different types of cold viruses, whether it's one of 50 different strains of Staphylococcus aureus, doesn't matter. Each one will be different. Okay? And it gives basically each one of these antibodies has the capability of latching on to two of those things, two viruses, two toxins, two bacteria, whatever. That's an important thing to recall as well. So as we go back to the previous slide, you will see that the so-called constant region falls into one of these 5 categories. They are all different. They perform similar tasks, but in different areas and under different circumstances. By far and away, the one we have the most of is IgG. So Ig stands for immunoglobulin. So just making it easier to pronounce, we say IgG, IgM, IgA, etc. The acronym I use, you pick your own. However, I never tell people how to memorize something because everybody learns differently. I use MATCH. Works for me. DMD doesn't work for me. GAMED doesn't work for me. MDEG, weird. MATCH seems good because I've known people who were named MATCH. Just saying. So, that's why I tell you these things, because these are just little tricks that I've used over the years. Anything that helps you assimilate material is important. So, by far and away, the one we have the most of is IgG. This is the linchpin. When you hear about antibodies fighting the infection, bacteria, virus, whatever, toxin, principally they're IgG. They are the ones that do most of the work. In contrast, IgM is the largest, but a relatively small percentage. And yeah, they work on foods and bacteria, and these work on bacteria, viruses, and toxins. That's not the point. The IgM is the first one on the scene. Interestingly enough, it's not necessarily the most abundant. And what we are able to do in the laboratory, we can test. We not only can we find out how many immunoglobulins you are, we can separate them by a variety of laboratory means. And you can separate them, and it's got a fancy name. It's called immunoglobulin electrophoresis. And effectively, we can find out proportions. And if there's a lot of IgM, typically it means it's early in the infection. If you test it later, let's say 10 days later, you should have relatively few IgMs and a whole lot of IgGs. If the person's not responding to treatment and you still see IgMs elevated, that tells you a couple of things. One, your treatment, whatever the treatment is not working, or there's some fault in their immune system or in the immunoglobulins. You see, information always tells you something. Sometimes the absence of information tells you something. So I have students ask me, none of these things tested positive. The fact that nothing tested positive tells you something. Okay? And the absence of the thing, sometimes it is telling us the presence of a thing. So I'm telling you that for the sake of completeness. So IgM, you'll see very shortly, is the largest, and the one that occurs, we see most frequently when an infection rears its ugly head. IgG is always the most abundant over time. IgA is in, and here's the watchword, it's a fairly large percentage in all of our secretions. Go back and look at what's in saliva, what's in mucus, what's in anogenital secretions, what's in respiratory secretion, what's in tears. IgA is in all of them. IgA, as you will see, is a dimer. In other words, there's 2 units. I'll show you in a second. And IgA is one of those things we're pre-programmed for. Those are the kinds of antibodies that we make, and they're sort of on guard generically for what we're likely to encounter. Foreign materials, bacteria, viruses, they're there. Their job is to basically get them out of the way before they cause trouble. As I say in my micro class, I said so earlier today, when it comes to infections, it's a numbers game. Okay, you have enough protection in your secretions on the surface of your skin, wherever they are located. to cope with most things. It's when they're overwhelmed. I mean, for instance, I ended up in intensive care with a salmonella infection in my stomach from something I had eaten. To be completely frank, I was very unhealthy. I'm infinitely healthier than I was then. I smoked like a chimney back then. I take 6,000 different types of medicine, none of which were good for me. Okay, and let me see how much exercise I did. None. I did a lot of this. Eat it. The infectious dose of that salmonella infection was to the order of about 1,000,000. I would have to ingest several 100,000 or 1,000,000 salmonellas to fight, for me to actually be infected. So it's a numbers game. But I had weakened my immune system for a variety of reasons that even if I had a relatively low dose, it not only did it make me ill, it got into my system and shut my kidneys down and nearly killed me. That was 19 years ago in July. It's okay. I'm here to give you the lecture. You didn't miss me. Didn't I tell you that story? They called. I was at St. Margaret's in Aspenwood. They called my 87-year-old mom to tell her I was close. I was 55 years old. How's that? Scared you know what out of my mom. I'm sure. Moving on. So that's what I mean. These are there to over. Normally, all that stuff I would have had in my alimentary canal, plus the acidity of my stomach, should have stopped that. It didn't. So I told you that maybe I ingested something that had a whole bunch of stuff in it. Maybe it was my own weakness in my immune system that wasn't being supported by the lifestyle that I had. It's probably a combination of both. The old story. IgD, we never really used to know what it was. We think it's one of the markers that's on B cells now. And IgE is super important. IgE is the one that mediates our allergic responses. The fact that my nose is stuffed now, my ear is clogged, if something happens this time of year, because this is why my allergies come out. Don't have it too much during the winter. Okay? IgE inserts itself into mast cells, which are modified basophils. What happens when they contact an allergen, they cause that basophil or mast cell to explode, and it releases histamine. And histamine dilates blood vessels, makes things swell up, increases mucus production, all that kind of stuff. Makes your eyes itchy, the typical things we get that are associated with it. And sometimes if there's a concentration in the respiratory area, and you all guys just did respiratory last time, blowing up a lung, okay, if it gets down deep in the lung, that's the kind of stuff potentially anaphylactic shock comes from. The very significant, very significant, because those mast cells, if they're in the wrong place and you explode too many of them, they too can be immediately life-threatening. That are there. This is what structurally now. That's why I'm going to escape and go to this other PowerPoint to show you. This is what it looks like. This is again the typical structure. So-called hinged regions, because they're not static. Living molecules in living systems, even though it's a molecule, can change shape. So they're flexible. We always think of things two-dimensionally. This is something that can latch onto things fairly easily by bending and shaping. This is where it binds. This is the variable end. Here's the heavy chain. Here's the light chain. Here's what it looks like sort of schematically. It's a big-ass blob of protein. I didn't mean to say that. I'm sorry. All I could come up with right now. I did that because I only swear if Maddie's not here, she couldn't be here. Here are your classes. IgM is a pentamer. So and this is, we did it in my physiology lab. We don't do it with A and P. It's like, and maybe you did it in high school. You prick your finger and get a drop of blood, test your blood type, that kind of thing. You know how it formed like little speckles if you had like type A pos or B, if you had type A or type B and it's speckled up a lot? That's called agglutination. That comes from this. It latches on It's got multiple places to latch on, and agglutination makes things that the immune system can't gobble up. It can't find because they're either so tiny or they're dissolved, and it agglutinates. And it does something called fixing and activating complement, which we'll get to. So it's the largest. IgA is a dimer, typically in mucus and other secretions. It's all about it's prevention from it getting started, latching on. This is what it looks like. Here's 1, 2, 3, 4, 5 of those Ys. Here are 2 of them sort of side by side, back to back, whatever works for you. So these are differently structured, where the other ones, G, E, and D, okay, are all monomers. So that's a useful fact to remember. I mean, is that something? Will I have a question pertinent to that on the exam? Probably. Is it something you should probably remember going forward for other tests? Yeah, I think so. So I think that's something that you should be about with it. And you can see plasma cells who make these can switch from one to the other, even though they'll be specific for that particular antigen. So you can make IgM and IgG to fight the infection. Maybe you can make IgA and goes out into secretions for a future challenge of the infection, etc. So there can be a lot of switching that goes on. And so this is what we're going to get back to, actually how they work. And basically what they do, understand, this is a really important point. Antibodies don't destroy the bacteria. They don't destroy the virus. They don't destroy the toxin. What they do is they act on it to stop it from hurting you, and it becomes identifiable, visible, whatever term you want to use, insoluble, readily available for your macrophages, your white blood cells, to do their job, which is to gobble them up. If it's a toxin, it neutralizes. If it's too little to be gobbled up, it makes it agglutinates it, makes a big clump of it, microscopically speaking. Okay? If it's insoluble, it precipitates it out. It takes it out of solution. Okay? So then it becomes effectively visible or available, would be a better term, to those macrophages to come along and thanks. It's like the door. Whenever I eat, he's there for crumbs. Chomp up. He sits with this giant head, this big nose, right on the arm of my chair when I'm watching TV, in the hope that something will miss. He has personality. So back to here, and I'll show you. So there's the one we saw before. This is just a summary of what they are, useful to look at. And you can see things that it does. The heparin that's released by the IgG is a pro-inflammatory agent, very potent in allergic responses. The IgM, where we see it, that's that mismatched blood transfusion things. It's latching on to multiple things. So that's the agglutination, that clumping that we see. And so these are the 3 major methods plus this. Don't underestimate complement. Complement, it's like complement, the analogy would be like the clotting factors that we talked about in the blood unit. Complement is something that's in an inactive form, and when our immune system activates, when antibodies begin to be made, a variety of chemicals are released, principally by things like helper T cells that we talked about before, and they start complement, and it's like a cascade. One makes another one, makes another one, makes another one. And they do all of these valuable things. We'll get to that in a second. So the basic way that antibodies work, they clump things up so they can be easily, all of these, the same thing, making phagocytosis easier. They precipitate, making them insoluble, easier to gobble up. They neutralize them. And that's the big problem with toxins, everybody. Toxins are toxins. They hurt things. So the first thing we have to do before we can gobble them up, we have to stop them from damaging tissue or damaging cells. And so you have to cover up those active ends. That's why toxins are so important. And indeed, when somebody, I was telling the other, I mean, this is somebody, if we think someone's at risk of tetanus, okay, and they haven't had a recent tetanus shot, not only do we give them the tetanus shot, we give them something called tetanus antitoxin. Tetanus, that tetanus shot's going to take 3 weeks, 4 weeks, 5 weeks to bring up to speed. You can die. Tetanus is fatal. Tetanus will go through your nervous system very quick and you will die. And if you don't give somebody the antitoxin, so a tetanus shot alone is not suitable for someone who has what we call a tetanus-prone wound and does not have reliable tetanus prophylaxis. Some of the anecdote about a friend of mine years and years ago when my kids were little and we were visiting them in Texas. He was a pharmacist for a big hospital corporation. He went around to all the different hospitals. He was the lead pharmacist for like 6 or 7 different hospitals in and around the San Antonio area. And we're staying at his house. I opened up, he had a little bar and had a little fridge. He was getting a soft drink. And I opened it up, and there's vial upon vial of polyvalent antivenom. So when someone's bitten by a snake, if you're not sure if they can't identify the snake, you give them a shot of an antivenom, antitoxin. Polyvalent means it's just for the usual, all the snakes that are indigenous to the area, you have multiple different types of antitoxins that are in there. I did wonder, since we were staying there, if I should be concerned. He goes, no, Lou, we're fine. He says, I have to run to these hospitals like every week, and they always need more of it, and they don't stock it, so I keep it here in my fridge, and I just, I drive from San Antonio to Houston or to Dallas or wherever. There, they a 3-hour drive they consider a straight shot because it's all super hot. I'll get there. We go 85 or 90 on the road. And here's compliment. So we're not necessarily attacking the antigens, but we're generating these other mechanisms. And so certain IgGs and IgM will activate all of these proteins that are coming. You don't have to go through the whole thing. In medical school, we learned about all of these and how they work. So they will affect agglutination. Remember, opsonization literally means to make tasty. It increases the ability of white blood cells to phagocytize. These are chemicals that summon the other white blood cells to the area. They will actually act to assist in destroying pathogens. They'll neutralize them. They'll even alter the structure of viruses. These, these are tremendously important chemicals that happen. Okay, so all of these things, and then additionally, the IgE. Yes, I know it's part of allergies, but something else. Some of those antigens will bind to that because it's not just in tissues where you have allergies, like respiratory or under the skin, but they will release inflammatory chemicals. And again, remember we talked about that. How it will lead redness and swelling and things like that. Inflammation is a positive thing we want to have happen as part of the fight because it limits the spread potentiality of infection. And they're just showing you some examples of agglutinating rather, precipitating, neutralizing, generically showing you how complement works. It can actually make cells lyse directly. It's such a neat little graphic, and not a big deal. Comparatively, and it just summarizes here all the different things it can do. So we have a lot of mechanisms that are part of this arm of antibodies. And remember, the way they're framed is called, we call this the humoral. When we remember, T cells are the cellular defenses. These are humoral, meaning they go in body fluids. So antibodies, complement, are all part of these. They're actually in the bloodstream. They're in the plasma. They're in tissues to start. We just have to activate as it were. And this is sort of the technological aspect of it. This is immunotherapies. Okay, so it's a two-edged sword. I am that person who's hit both sides of this. The way I frame it, they started me on immunotherapy in 2015 or 2016 and discovered I had bladder cancer. Bladder cancer was because 99% of people with bladder cancer have a history of smoking cigarettes. Well, even though I had stopped 7 or 8 years earlier. So they did immunotherapy. basically they give you, it's immunotherapy. They're giving you a bacteria that is designed to, because it's sucked up readily by your cells, it tends to trigger those cells to generate the immune response. So there's lots of, basically it's bolstering your immunotherapy means it's something that's bolstering your own immune system. It was so vigorous for me, the immunotherapy, that it likely activated either a hereditary tendency or some tendency I had individually, and I actually developed an immunological form of arthritis, true inflammatory arthritis, a variant of something called ankylosing spondylitis that I had never had or had any problems with. And so it caused a major flare. So not only did I have to stop the immunotherapy after maybe less than a year, and thankfully I've never gotten the cancer back, that I had to stop the immunotherapy, still working with my urologist, and had to go see an immunologist who started me on two immunosuppressive agents that are made by, we call them biologicals. One, and you've seen them advertised on TV, one called Cosentix that I took for a while that blocks something called IL-17. That IL-17 increases inflammation. My inflammation was so bad, I mean, I could barely move my hands. I was just so, it's such terrible pain that I had to, that helped, but of course it was very difficult to tolerate. I could hardly teach. If I take a shot of that, I mean, for like a day, I'm like, not quite sure where I am. It's like, I feel so out of it. So they got me off of that and put me on something called anti-tumor necrosis factor that you see advertised called Humira. It's another another biological. And I was using that, and the same kind of thing happened, though not as severe. Yeah, my arthritis got better, but I didn't feel overall better. And I got to the point where I felt that since the flare was due to the immunotherapy, that the treatment for the flare from the immunotherapy was almost as bad as what I had going into it. And so my decision was, I talked about it with the rheumatologist. I said, I'm just going to stop all this stuff, see what happens. I mean, since then I feel physically better. My arthritis could be better. I have really bad shoulder arthritis. I can hardly move them in the morning. But by the time I get here, I'm pretty loose. But in the morning, I mean, if I imagine trying to turn the switch on your lamp from your bed, hard to do. So that's sometimes you put up with those things, but I felt better not on the medicine or not. So that's an example of immunotherapy. Monoclonal antibodies have been around for a long time. We get a specific B cell, producing one type of antibody in the laboratory to actually influence it with a cancer cell, and that's what, and it just produces large amounts. They were extraordinarily useful treating COVID-19. They were probably the most effective, quote unquote, treatment for COVID-19. They were, a lot of independent labs were doing it. They were getting compensated by the government as long as you had a positive COVID test. My middle one, who I mean, he was I think he was still working propane at that time. He was working propane now. So he drives hazmat type stuff. It had nothing to do with the hazmat. But he felt lousy, tested positive. And there was a place in West Mifflin that was giving this. As long as you had a positive COVID test, he would pay the $2,000 for this infusion. Not innocent. I mean, he said they held him there for several hours because he was in no shape to drive. I said he drives professionally. So I mean that it was a very useful, and it's been around to treat other things as well. So I mean, as you research a variety of things, pregnancy testing, there's a variety of different agents that have been used this way. So monoclonal antibodies have been used. Okay, this is what I was talking about. Large quantities of these effectively cytokines, whether it was what I took, something that opposed IL-17 or something that opposed tumor necrosis factor, they basically were used to treat a variety of things. For years, when we first discovered these chemicals called interleukins, short for IL, that was one of the initial treatments to treat things like MS, hepatitis, all of these kinds of things that you can see here, leukemia, interleukin 2, okay, because it was it's really the main product, the most, I hate to say most important, but a vital product by helper T cells that bolsters your whole immune system. They were using that. So interleukin 2 therapy's been around for a long time. And I'm not familiar with this antigen receptor T cell. I do know, I think this basically, I think it's effectively you extract T cells, you extract blood, and you extract T cells from the areas surrounding a tumor, you isolate them, you chemically treat them, and then you cause them to be produced in large quantities and re-injecting them. And that's the treatment. It was one of the early treatments for melanoma. And I'm thinking it's the same thing. I'll have to look it up. But the really interesting part and where this ties into vis-a-vis immunizations is this. This is effectively when you get exposed to a disease, we call it the primary response. If you're going to produce antibodies, once the B and T cells, those plasma cells that make all those antibodies, and also release the IgM and then the IgG 5 to 10 days before you reach adequate levels to treat the infection. That's the first response, but you develop memory cells. The second response happens almost immediately, within hours to days. You produce extraordinarily high levels in a very short time. That's what an immunization does. In other words, what an immunization does, I had measles as a kid. I had chickenpox as a kid. We didn't have the immunization. I had German measles as a kid. I got natural immunity from that. Okay, I had the disease comparably mild, or if not mild, I was only sick for maybe 5 to 7 days. I was surprised if almost all of you surely had the MMR for measles and mumps, and you probably had the chickenpox shot as well. They basically took those viruses and we call it attenuating them. They altered them so they still provoked your immune system, but you didn't get sick. The whole idea is if you encountered them again, you would ramp up and produce antibodies so rapidly you wouldn't know you had it. That's how it works. And that's because of memory cells. And it can be a lifelong kind of immunity. Sometimes you need to get a booster shot for it. It's a very reflective chart of this. As you can see, that first exposure, up to 10 days. So what's familiar about that? How long do we prescribe antibodies for most people? Effectively 10 days. Even the Z-Pack, which you take for 5 days, is designed as a time release type of product that effectively still has peak activity up to 10 days. That's why it's so important clinically for you to tell people, if you're getting antibiotics, if you're the nurse, if you're the physician, if you're the nurse practitioner, whatever role you play, follow the instructions, take the antibiotics the whole way. That's the idea of that. You're trying to treat that first exposure. After that, if you encounter the same thing while you have that immunological memory, that second response will occur almost immediately at much higher levels. That's the whole logic behind various kinds of immunizations. And so this is how we get them. So for me, active immunity means I obtained it via direct contact. Immune response was evoked and memory bestowed. We call that naturally acquired, such as getting and recovering from the disease. Okay, that's naturally acquired active immunity. Okay, if I get it artificially acquired, then it was, rather than being a natural process, I got that from receiving an immunization. So that's active immunity, but artificially acquired versus getting sick, naturally acquired. When you talk about passive immunity, passive means temporary. You naturally get passive immunity when you're bored. So whoever your mom is, and I remember I phrased it that way, I used the term birth mom. Don't be offended by that. I have 3 adoptive children. Okay, so we use the term birth mom in the adoptive world. Okay, and that basically, from your mom, you get her antibodies, and they cover you for about 6 months until your immune system starts to ramp up. Okay, That is a natural process. You can get them artificially. That's like that gamma globulin I was talking about. That's an injection of an immunological agent, such as like an antitoxin or an antivenom or gamma globulin. And so it's passive, temporary immunity, and the watchword is temporary. You didn't have an antigen exposure, no immune response is evoked. And they just summarize these here. A nursing mom imparts some of that as well, probably for a bit longer period of time, obviously, as you would suspect. And we start to talk about the very end with the last group, so it'll be the very end for you folks, are really when we start to get it, what happens when the immune system does something unexpected. We call them hypersensitivities, and allergy would be the classic one that most of us have. And allergies can occur at any time. All you need is a sensitizing dose, one exposure, and you can become allergic at any time to any subsequent exposure. And I'll tell you the same anecdote I tell to everybody. I had a nurse that I treated who had retired. She was a diabetic lady. She was by history not allergic. I said, "Are you allergic to penicillin?" She goes, "No." I gave her a prescription for amoxicillin. She had an infection in her foot. The next time I saw her, about a week to 10 days later, I wanted to see her in 3 days. She was in the hospital. She came in, and I had already talked to her physician, and she had who was treating her diabetes. And she comes in and goes, that medicine you gave me, I had a terrible allergic reaction to it. I ended up in the hospital. And I said, well, you told me you had taken amoxicillin before. She says, I have many times. I don't know why I was allergic. The answer is nobody does, because you can have an allergic reaction at any time. Absolutely true story. You could eat peanuts, and all of a sudden you can't eat peanuts anymore. You could have soy products, and all of a sudden you can't ingest soy, and soy is everywhere. These are the kinds of things. You read all those labels. Ooh, lots of stuff has soy. So you've got to be really on top of those types of things. It's an exaggerated immune response. You have to be sensitive. They can affect almost anybody. Okay. Does heredity play a role? I would guess so. I don't know. I can't really give you chapter and verse on it. It's all about those IgEs. They respond to the allergen. Sometimes it's like a pollen. That's one of those HAP10 or half antigens. They attach to a protein inside of you and trigger the response. And what happens, and immediately, you get a rash, or you start to cough or sneeze, or you have difficulty breathing. Okay, it can be just typical, like I have hay fever type general allergies, or you could have hives, which are very distinctive. Okay, some type of skin presentation. It could be gastrointestinal, or it could be as severe if they're clustered in the small bronchioles in your respiratory system as anaphylactic shock, which is immediately life-threatening. So there's a whole lot of these things that are there, and you have to be very, very aware. So they can go be something that's annoying, and you probably can control, like I do with the Zyrtec on a regular basis, or spraying my nose with some of those steroidal nose sprays that we have so commonly now. Or it could be more severe. You really have to be very, very cautious. That's why if you're in patient care and you ask a patient, you go, it's not when they say I'm allergic to something, find out what happens. They start talking about rash and difficulty in swallowing, or trouble breathing, or swelling up and blowing up like a balloon. That's a real allergic response. Stomach is very non-special. If someone says I have a headache, that's not really an allergy. Gastrointestinal, it depends specifically on what it is. Some things you're more likely to have it than others. Then you have to be watchful of it. But it's typically not something that's going to be immediately life-threatening. So it may just be a side effect to a particular medicine as opposed to a true allergy. These are other ones. Type 2 is the kind of thing in transfusions you worry about. That type A and type B intermix. Because then you form these antigen-antibody complexes. And because it's red blood cells, you get a lot of hemoglobin released, and it clogs your kidneys. And that can shut your kidneys down and also be life-threatening. That's the classic type 2 hypersensitivity. So it's antibody dependent and it's cytotoxic. The cells happen to be red blood cells. And the type 3, these are immune complexes. This is what diabetics with type 1 diabetes get. That's why we were pretty sure there's an autoimmune phenomenon that's involved. They have some kind of immunologic, because we get these large clumps of antibodies and antigen complexes, which are thick proteins that settle in organs, including the kidney. Okay, and over time damage them. Okay. Or something like systemic lupus erythematosus or rheumatoid arthritis. We get deposits in organs that damage them over time. Okay, and the complexes can't be cleared. Like I said, the type 2 is a little different because of the hemoglobin that's released and the damage it does specifically to the kidney. This is multiple organs. And lastly, for today, the type 4, again, this is the delayed reaction. And so what happens is results from repetitive exposure to an allergen activating T cells in the skin, which become inflammatory. And it typically takes 48 to 72 hours. That's the TB test that we all get. And many of you are going into a clinical field every year. You're going to end up with a TB test because tuberculosis stays in the air. So you may be inadvertently exposed to it. More people have been exposed to it than you think. So when they give you this shot of a protein, it's called PPD or purified protein derivative. If you blow up right away, oh my God, it's swole overnight. That's not a positive test. That's an allergy. The positive test occurs 48 to 72 hours and has to be measurable and follow certain guidelines that are associated with it. By definition, it's delayed reaction. A variety of things. Contact dermatitis, poison ivy are also in that category, 48 to 72 hours. That's everything for today. We'll see you guys on Wednesday. I'll have more information on what we're going to do about this exam. I'm going to run the numbers and see what the timing is, and we'll go through it from there. Thank you. Bye-bye. You're welcome.